Hi, I am Dr. Hondani, surgical gastroenterologist. Today I am going to speak about carcinoma pancreas or pancreatic cancer. Pancreatic cancer is a very serious condition because once it is diagnosed, survival rate of the patient with pancreatic cancer is less than 50% for 5 years. The reason is most of the time the pancreatic cancers are asymptomatic till they become stage 3 or stage 4 and we come to know about them very late. The most common presentation of pancreatic cancer in case of it is head is usually present with jaundice. So otherwise the other clinical symptoms are very vague. Usually they present with vague abdominal pain, back pain or abdominal discomfort or unexplained weight loss. So only if a lesion is in the head of the pancreas near to the common bile duct, then these patients will present with jaundice. So if the pancreatic cancer is clinically apparent, means we can diagnose clinically, that means it is very advanced. So what are the risk factors for carcinoma pancreas is mainly smoking, alcohol consumption, chronic pancreatitis or genetic. If patient has a genetic history of pancreatic cancer, then there is high risk of pancreatic cancer. So now how do we screen for pancreatic cancer? There is no specific screening for pancreatic cancer. Usually most of the time we will come to know by doing an ultrasound scan, or we have done a scan for some other reason, then we will pick up the disease. So if a patient has a high risk patient, suppose they are chronic pancreatitis patients, or they are smoking, or a family history of pancreatitis, then they should regularly undergo ultrasound. Usually chronic pancreatitis patient, best way to follow up is doing a yearly MRI, because MRI doesn't cause much of radiation but it will pick up the pancreatic tumors. So once we think that patient has got a pancreatic cancer, how do you evaluate? Usually we ask for a CCT abdomen. When you do the CT scan, we'll come to know where is the lesion, what exactly the lesion, exactly position of the lesion, whether it is in the head or in the body or in the tail of the pancreas. So most of the time, the space African lesion in the pancreas is sufficient to diagnose and plan the treatment. We get the tissue biopsy by doing endoscopic ultrasound. Once we do the endoscopic ultrasound, we'll take either FNAC or a core biopsy, then we come to know about the diagnosis. The drawback with the endoscopic ultrasound is it is positive only in the 30% of the cases. Remaining 70% of the cases, even if tumor is there, it may show as negative. So whenever there is a space occupying lesion in the CT scan and CT features are suggestive of cancer, we'll offer the treatment. So treatment of pancreatic cancer is surgery. That is the first line of treatment. So whenever tumor is we are able to resect or we diagnose carcinoma pancreas, we see where exactly it is and whether it is related to any major blood vessel or any blood vessel reconstruction is required or not. So once this is done, then we plan for the surgery. Surgery we will do either open or laparoscopic based on the patient condition, based on the anatomy of the patient, and also availability of the resources, or whether patient is able to afford laparoscopic surgery. But laparoscopic surgery can be done in case of pancreatic cancer. So the surgery is the first line of treatment. Suppose if patient the tumor is little bit advanced involving a small vessel, maybe part of the vessel, then what we do is we'll give a chemotherapy and downsize the tumor, then we reassess, then we offer the surgery. Most of the time only around 30 to 40% of the patients we will be able to offer surgery. Remaining 60% of the times the tumor is already advanced when we clinically diagnose. And the other thing I see among the patient is we diagnose the patient that patient has got carcinoma pancreas, it is offerable stages, and we say that we will plan for surgery. The following that they do is something called doctor hopping or doctor shopping. They take on 1.5 months to come to a conclusion for the surgery. By the time they come back for surgery, what was operable becomes inoperable. So my message to all the patient is, see, whenever cancer is diagnosed, no doctor is misleading you. The cancer is there, and you need to understand is cancer doesn't wait for your decision. It will continuously grow, and how long you take for the treatment, during all the time the cancer will be growing only. So if you delay in the decision or you take multiple opinions, the problem is By the time you come to a conclusion, what was operable many times becomes inoperable. This is happens regularly in our practice, and more so I don't understand like what is the logic behind it among the patients. And second thing is, whenever we say patient has jaundice or because of carcinoma pancreas, and mostly rural setup patients, what they do is they go for Ayurveda and they try for 1 or 2 months, then they come back and ask for the surgery. By the time what was operable becomes inoperable. I feel sometimes it is lucky to have a jaundice, because whenever patient develop jaundice, even the small tumor when obstruct the CBD will present a jaundice. So usually it is much earlier stage. So when we operate, you will get cure and have a reasonable lifespan and good quality of life. If the patient has got a stage 4 disease, a stage 3 disease, then chemotherapy and palliative therapy is the only option, because carcinoma pancreas is a very aggressive disease. We'll able to save the patient only if we diagnose much earlier stage and treat aggressively by doing surgery. So surgery is the first line of treatment for carcinoma pancreas, and chemotherapy is only help us to downsize the treatment or in a palliative phase.